I'm going to wait for you because there's about 20-second delay. I'm going to wait for you because there's about 20-second delay. Okay, good. Okay, that should be fine now. I think we're okay. You know what I'm going to do? Anthony, I think you can hear me now. Okay, good. Okay, that should be fine now. I think we're okay. You know what I'm going to do? Anthony, I think you can hear me now. Okay. You can turn the volume down here. Yeah. Perfect. You can turn the volume down. Okay. Are you streaming through the wireless network here in the office? Okay. Yeah, you know, if it's the wireless, then let's turn it off because I know it works now. Let's turn it off because I'm just checking it. Perfect. That's great. That works. I'm just going to wait for Anthony. The microphone icon is gone from top of the broadcast window. Okay, we did some testing right in here. We could hear me. Let me see. Can you hear me now? Let me see. Microphone is on. Screen share is on. Okay. That's a good idea. Let's try to log off, to exit and log back in. Let's try I think we should be fine. Okay, Anthony's going to try that. That worked pretty good. So we know it works. Anthony, we're going to wait for you. Everything depends on you. Okay, the world of surgery. Can you hear me now? Give me the thumbs up. Thumbs up. Yes, can you hear me? Let's see. Thanks, guys. Okay, so what I'm going to do, I'm going to give a little, kind of go back in the slide. Just give a little quick recap. Loud and clear. Terrific. Okay. Okay, so I'm going to give a quick recap. Not going to waste all this time because some of you guys will see this as a recording. So welcome to CGI box number 1. I'm going to show you how we plan a lower molar, and hopefully those in CGI box module number 1, you were able to plan. Even if you didn't, I hope this module will inspire you to learn more CGI. So basically, all you need to do is log into CGI box, go into CGI box number 1, and then you have the option to follow the instructions, go videos, and follow the instructions on how to use the data sets in CGI box CD number 1. You'll find the DICOM data, the STL data that I'm going to review now. Or you can click on a link that takes you to my Dropbox, which is basically saving it on the cloud platform. And I suggest you have that and find the DICOM and the STL that you're planning. Okay, again, for attending most of the docs morning. And we do this on provide the training into morning, and our doctors cannot attend. We have close to 100 people course, so it's kind of assuming to 12 live trainings, but if you don't information, then you're not making. I want you to be successful and be able to do what I do. Okay, so in the module, you'll learn sets, how to use the DICOM, how to use the STL, import them into the Blue Sky Bio software. Again, you don't have to buy a software. Okay, use the free Bio and learn how to use it as many times as you want, and then you can either keep using it or you go for another software, but you learn very, very important principles. I'm also going to show you how to use the implant software. And the way these trainings are going to work out is you'll use CGI box data sets give you CGI advice and tips and tricks, and review the surgery that you planned in the module and answer your questions. That's basically how it's going to work out. Now, every live training, I'm going to talk about some of the important guidelines, steps, frameworks that are important for you to become a surgeon, a great surgeon. And the idea here is not just to learn techniques step by step, which is important. The idea is to adapt a certain mindset, a certain attitude towards X, be like a cookie cutter, just leaving dental school and doing the things the same as you've done 10 times, because things are changing and you need to be ahead of the curve. So I talked about, in previous trainings, I talked about adaptability. As a surgeon, you need to be able to adapt to different situations. You need to have patience. It's not going to happen overnight. You need to keep practicing. You need to go through complications, and you need to have patience. Meaning patience, you need patience to work on, but you need to have patience while you actively treat them so you can learn and get better. Now, I talked about the aesthetic zone where important, and I also talked about how important it is to have true grit, meaning to have some, be tough, patience, which will happen. And once you have complications, and if you're not, didn't develop enough toughness, enough thick skin, you're going to start crying and go home performing surgery. We don't want that. So we need to develop some mental toughness to deal with difficult situations. Now, when it comes to like what you may think guided surgery is, uncomplex it, decomplex it, turn it into something more simple, and I call this trait simplify ×3. Make things simple. Keep the simple. There are complicated things in life, to be honest. There are things that are, we don't have solutions for. If you wanted to, kind of send a rocket out of space and send the man to the moon, that's not simple at all. But in surgery, most surgeries are actually simple. If you're practicing in an average practice, in an average city, in an average patient, what's going to come your way every day? Somebody with missing molar, or a molar needed to be extracted, a broken central incisor, premolars split in half with an endo failure. Simple things. So if you are now going to take every case and overcomplicate it, number one, you get frustrated. Number two, your treatment is not going to be successful, or not likely to be successful. Why? Because you're taking too much time with your planning and focusing on basics and predictability and simplicity. Okay, they say that simplicity is the ultimate sophistication. I think it was Leonardo da Vinci said that. Simplicity is the ultimate sophistication. So, hey, you want to be sophisticated, keep things simple. And I think I was told before, why do people like to attend my courses and lectures and attend the online training? Why? Because I try to simplify things. So also from a teaching point of view, and you teach your patients every day and present treatment plans and market your treatments. If you're going to market something so complex, nobody understands you, result that you want to simplify. Okay, Anthony, I hope you can still hear me loud and clear. If you're watching this as a recording, then leave some comments and questions below. Again, we have Dr. Andy Kumar here from Sydney, Australia, SurgicalMaster, enrolled in the Implant Gold Rush Master's course. Sitting here next to me, you may hear his voice. I may ask him some questions. And this is how it is, when you develop a passion, there are no more borders. He came here to take the pinhole surgical technique course, and now he's visiting me and learning and getting better, okay? Active patience, it takes time. Guided surgery, okay? So CGI, which is the focus of this training, is unbelievable. It's an amazing treatment modality that unfortunately only a few dentists are taking advantage of. Why is that? There are a lot of misconceptions out there. There's a lot of fear of the unknown, fear of inaccuracies, and there's nothing more accurate than CGI. And I'm going to talk about it and show you throughout this training. But the reality is that we now think that probably about 10 million implants are placed a year, just an estimation. Maybe 1% of a percent is done guided. So here's the opportunity. If you are in your community a doctor, a dentist that is placing implants fully guided, I can basically show you my marketing plan, how I marketed myself as a CGI surgeon. And you would think that in Beverly Hills, the creme de la creme of society and all wealthy people, you would think that there would be more surgeons placing implants guided. No, that's not the reality. It's not a very well utilized treatment modality, and it's a shame. Now, CGI is only part of the big picture of being good at implant surgery. It's only part of it. Of course, the extraction process, the bone and soft tissue grafting are critical, the implant positioning, the restorative treatment. And where's my phone here? Where did I put my phone? Here it is. Let me just answer. My wife is texting me while we give this training. So the CGI, the role of CGI is purely placing implants accurately. It does not increase your success rates. It does not make your implants more. Proper positioning does affect the wow, being bombarded. You have to work with text messages. I'm sorry. That's the clicking that you hear, the sounds. Implant aesthetics is affected by positioning, no doubt about it. But the only goal, the pure goal of guided surgery is to place the implant in the right position, which is huge. A lot of doctors are not placing implants because they can't get them right, can't get them at the right angle. They're all crooked or too buccal, too lingual, too apical, too coronal. And no wonder, because I would be the same. I don't have any magical skills. I have maybe a lot of experience, but I don't have any magical skills to be able to drill in a straight line or in a line that I want, because this is now in three-dimensional. Once you reflected the flap, once you place multiple implants, you lose all orientation. And if you try to do it freehand, yes, you can probably be successful, probably get lucky a couple of times, but many times it'll be a disaster. So who wants a disaster? The disaster of a malpositioned implant means a lot. You can't afford too many disasters, too many complications. Okay, so just for us to remember, CGI does not mean flapless. It has nothing to do with that. CGI does not mean immediate placement. It has nothing to do with it. CGI means placing the implant properly, accurately, and precisely. Okay, just everybody to. You see, surgical became, and it is really accurate or doing very, very accurately or precise. They say it has surgical precision, but is that implant surgery is not precise at all. Precise at all if you do it freehand, because you're relying on your patient that is moving, and you're relying on your 3D perception of drilling in the right trajectory. And we found out experience of 10, 20 years, thousands of implants, still mess it up a couple of times. So CGI is about to prevent it. Now, why are people reluctant to use CGI? Well, I mentioned before, we are afraid. We're afraid of new things, just thousands and thousands of dollars. I already proved to you in CGI Box that you don't have to spend a penny, meaning you have to join the course. It's software. You got a guided software. You don't have to buy a software for 5. Blue Sky Bio is great. print a guide, okay? That's something else. You source it out, so it's going to, but pay for. So doctors are reluctant. There are some surgeons that don't believe in the accuracy, and I can tell you from personal experience, and the cases properly will go exactly that. And we actually had an experience this morning, and Andy's now, he saw the surgery. We saw that one of the implants was good, and we went back to the software, and indeed my was misplanned. I misplanned it for, okay, maybe it was an error in submitting file, but this is how it's going to go. Okay, so that's the reason for the reluctancy. Now, some people, accuracy and precision. Accuracy is, are you tied to the middle of the target? The more. Now, what's precision? Precision is basically the distribution. So if you're a precise surgeon or a precise sniper, is going to be, now you can be very, very precise, but not accurate at all. You can place your implants all the time, the same way, the same angle, but target. So guided surgery really allows you to be accurate and precise. I have a few on my YouTube channel that talk precision. Look at that. I just wanted to review this course. Guided surgery, the power that a seasoned 20-30 years of experience do with that guided surgery. You can put a lot of to shame. Not that we want to do that, we're bad, but you can in these techniques to place your implants so precisely, like place thousands of implants, better than them, which I think is amazing. A doctor who just graduated dental, how to place implants with almost no experience, will be able to do that. Now, again, accuracy and precision. I'm not saying that after you know everything about bone grafting and treatment planning, treatment of complications and sinus lifting, but in terms of accuracy and precision, way ahead of the curve, way ahead of everybody else. What is the key? Accuracy and precision in surgery. If you want your surgeries to be accurate and precise, you need to collect data that is accurate and precise. You see, it's all going to trickle down from your impression taking to the surgery. So if I'm slacking off, I'm using only alginate, and my impressions are not accurate with a lot of bubbles, and whoever pours them doesn't, everything is deformed, you know what? Your surgery is not going to be accurate. So as good as your data collection is, this is how good the surgery will be. Now, there is a saying that goes like that. How you do one thing is how you do everything. Okay? So if you're slacking off in one aspect of your life, let's say you leave the house and you don't take showers and you don't shave and you don't dress up nice, you know what? If you work as a doctor, you know, you work the same. You'll be sloppy. I believe in it, because that's your character. And I'm not saying that's your character watching this video, but how you do one thing is how you think. So do everything as best as you can. Aim for excellence, okay? Chase excellence and get those impressions right. And if an impression didn't come out right, retake it. Retake it, okay? It's like sending an impression to the lab and you don't see the margins of... Listen, nobody is perfect. I've made many, many mistakes. But how you do one thing is how you do everything. So take great impressions, get those study casts, and typically what we do, we take those casts, we take an impression of the wax up, and we did. Now you can also get an STL from a PVS impression. You can do that. You can. But I don't know the technology of how to do that, Anthony. So you'll have to learn that. I know that Blue Sky Bio allows you to take a CT scan of your impression, and off the CT scan, they can build a model. I can tell you now, at the moment, it's not 100% accurate. So the best I can advise you right now is don't look for any shortcuts. Either take an of the patient's teeth, meaning an optical scan, or take a PVS impression. Okay, so it'll cost you $15 for the impression material, but you'll get an accurate that you can then digitize. Okay, when I say you, that you will have digitized, you don't have to do it yourself. You submit basically to the guided company, and they will scan it for you. You source it out. Now, if you have an optical scanner, you don't need the impression. Okay, and I'll talk about the question whether you need an impression, an optical scanner or not. That's very important. Okay, so accuracy in impression or an optical scanning device is submitted to a company, of course, with DICOM images. Now, DICOM also has to be accurate. So if you have your own scanner, you train your staff to take good scans so the patient doesn't move. Make sure there's not too much scatter or no scatter next to the implant site, because again, if you have an inaccuracy in the DICOM data, then these inaccuracies are going to trickle down. And only when you have good STLs, good impressions, and they're being, then you can plan your implant in surgical position. Okay. Now, a lot of doctors ask me, part of this course, sorry, with DICOM, what do I need to know about DICOM? Well, you don't need to know anything. You need to know that the CT scan is basically made out of multiple files, and multiple files called DICOM. Okay, each file, and you'll have about, let's say for a full arch, you'll have about 100 to 200 files, and it depends on the thickness of the slices. Like Anthony is saying here, you don't have to have slices that are that thin, 0.1 millimeters. You don't need that, and that's going to slow down the work with the software. The more DICOM images you have, it's going to slow down your computer power. It's going to take more memory. You're on your computer I found that it doesn't make any difference if you have more slices or not. Of course, if you have too few slices, you don't have enough information, and you may miss an important point of information in one of those slices. But 0.1 millimeters is quite adequate. So I look mostly into how many files. Okay, so all you need to know about DICOM is that this is what you have in front of you as part of CGI box. Each CD has DICOM, and it says it very clearly: DICOM number 1, DICOM number 2, 3, and so on and so forth. And it has the SD, so it'll be around 100 megabytes, around that. Now, another doctor that I actually personally met with asked me, so I'm about to start placing implants. I'm about to get into guided. I've never done an implant. So which scanner should I buy? Basically, I told him, hold on, why do you need to buy a scanner? And he says, don't you need a scanner if you're placing implants? And I said, no, this is not like restorative dentistry or endo where you need to have an X-ray. Okay, every dentist needs an X-ray, of course. But to place implants, you don't have to have your own CT scanner. I mean, it's an advantage. I don't have one. I don't have one in the office. I source it out. We have a great lab next door, and there's no right or wrong, but this is a significant expense. I know that the prices are going down, but it's still $100,000. Okay, I have a lot of things to do with $100,000, and if I have this monster in my office, and again, I'm not saying it's the wrong thing to have a CT scanner. It takes space. It's not always productive, and in 2 years, it's going to be outdated. So think very, very well and enough before you buy a CT scanner. Now, I'm planning to buy one, by the way, having said that, but that's not the right timing for me right now. I need to do a little remodel. I need to create some more room, and I need to figure out the workflow. I don't just want to buy a CT scanner and then have it sit there like like an elephant in the room. Just nobody's using it, or I'm forced to use it because I need to make my payments on the scanner. Okay, so think well, but you don't need to have a physical CT scanner to be able to place implants or to do guided surgery. You simply refer the patient to a radiologist, and you get the results the next day. No big deal. Now, the CT scan reps that knock on your door, they'll tell you, Doc, you're going to lose the patient. Your patient is going to go somewhere else, and if you don't get the CT scan right now and do the surgery right now, you're leaving a lot of money on the table. So, I can tell you one thing about that. If you're losing a patient because you send them out for imaging, you have other problems. You need to work on patient communication and treatment presentation, and case acceptance, and building rapport with your patient. And so you're not afraid to refer the patient out, because if you think in a scarcity mindset, or you have like an urgency mindset, I got to do the treatment today or the patient will run away, it's unhealthy. It's unhealthy for you, it's unhealthy for the patient, and your patients will run away because that patients want to see a doctor that is not in a rush. And yes, having technology in the office is a great thing and it's a convenience, but by referring them out to an imaging center, which I have done for many, many years and still doing, I did not lose a patient over that. Okay, but I think once I get my CT scanner at some point in the next couple of years, I think it'll be a convenience for me because I'll be able to look at the scan. Now, you can also think about buying an optical scanner, not to take physical impressions, and I think that's a great idea. Great idea to take physical, to take very accurate. They're already digital. You don't have to digitize anything. There's not too much distortion. And I'm planning to buy one myself. Okay, that's on my plate, and it's not 100,000. It's probably around 20 to 30,000. Okay, and that's still an expense, but I think it's an expense that is well worth it. I just spoke to a dentist last week, and he said, I'm spending $100,000 a year on impression material. I mean, that's a lot of money. Buy an optical scanner. Why not? Okay. Now, once you have an optical scanner, it makes your life easy. Y8 STL file for stereo lithography. Doctors asking me, oh my God, STLs, it's off. What do I need to know? You need to know nothing. The digital impression or a digital model gets incorporated into the software of taking the impression with actual and pouring it and so the file. Okay, STLs are provided in AGI box. Okay, and the links provide you with an STL, and to combine the two, how to merge the two. So let's have let's have a big picture view on guided surgery. Okay, the first thing that I like you to focus on is know implant positioning, or know the implant positioning rules, and just the basic rules that I review in my videos. You can now see them also in the recorded live lessons from the broadcast. Okay, that's a separate product that you received, and I talk about some principles of implant positioning. Okay, that's super important. If you don't know that, then how are you going to plan? How are you going to plan your implants? Based on what? Based on what knowledge? So that's really critical. So you have to know how many millimeters to stay away from the nerve. You need to know, let's say, how far you can get close to a tooth, how far implants need to be spaced from one another, the position of the platform, how deep subgingival, how deep subosseous. You need to know all these rules before you get into that, okay? And this is actually relatively simple, okay? Andy's a little bit sick here, so he's coughing a little bit, but it's not a big deal. Don't hold it in, okay? Okay, so you need to know that. Once you know that, the next step is get the data. Get the data. What does that mean? Get the data means get a CT scan, okay? Get impressions, physical impressions, get optical scans, and get them merged inside a software. Now, where do you get the data from for CGI Box? You get them from the CDs or from the link. So every module has links where you can download the data. Okay, I hope this is clear. I hope I demystify a little bit what you need to know, what you don't need to know. So DICOM, it's a digital data set of the CT scan. You want to read more about it? You want to learn more about it? Absolutely, it's interesting. Technology is fascinating, but you don't really need to be an expert in that. All you need to know is I need to take this data set and feed it into the software. Same thing with the STL. The software needs the STL. Sometimes it needs a couple of STLs with and without a tooth, or with a wax up or without a wax up, and feed the software and then go through a process of merging. Now, Anthony is asking something called pre-merged. I'm not sure what you mean. Maybe you want to clarify what you mean. Once you have the data set, it's being placed in the software. Now you're going to analyze it. You're going to analyze the data. You're going to plan your implant. You're going to study the anatomy. You're going to study the ideal restorative position. And you're going to simulate the ideal positioning within what is presented to you. Okay, and only then perform the surgery. So I hope you have now a pretty good big picture view on how guided surgery works. Okay, all these very important steps that are worked on, that I'm going to work with you on as part of this course. Is it possible to insert a merged file into Blue Sky Bio? Well, it has to be a merged file by Blue Sky Bio. Okay, so this is like a PC file, a Word document that is in PC and in Mac. They will be interchangeable. Okay, the software can read both, but it doesn't work the same between the guided software. Okay, so if you take a pre-merged file and you save it as whatever format, a different software will not be able to open that, Anthony. It's not going to work. So you wanted to clarify, get someone else to merge the CT scan and STL? Absolutely. Don't do it yourself. Absolutely. If you're asking to get them pre-merged, it's absolutely get somebody else to do that. But all I did in the modules with the Blue Sky Bio is show you how to do it, and I want you to do it. I want you to get the experience, but it's, you see, sometimes there are problems, and I alluded to them in the training, and it'll save you a lot of time. I like to upload my data sets into the cloud, into the company, or for the company to merge, and a day later I'm getting a merged file. Much better that I can plan. I want you guys to be productive and focus on the actual work. Okay, a couple of important points to CGI that really make a big difference, huge difference between a success and a failure. Starting with timing, and I'm going to give you tips every we conduct. I'm not going to overwhelm you. This is a relatively short training. We're going to be done probably in about 20 minutes, half an hour. So timing is everything in life, but also in implants. surgery. What is timing? Timing is the platform around its axis. Okay, so now depending on what times, there's a 6-3 positions, sometimes 7 positions. It all depends. Important. Timing is important if you prefabricate a provisional. If you prefabricated let's say an implant temporary, and if you didn't get the timing right, think about it. The temporary crown is only going to fit one way. Now, if you got the timing wrong, the crown will fit by guided surgery. And I showed you in IGR number 3, if you want to check it out, IGR 3, aesthetic zone, and I showed you these timing notches and how timing is super critical in those fit. Now, if you're using stock abutments, again, not that I encourage you to use stock abutments a lot, but sometimes we do, especially the ones that have an angle. You need to orient the implant a certain way. Of course, there are different stock abutments, okay, but that makes a difference. So that's about timing. How about the actual tube? Every guide has a tube through which you are drilling and creating your osteotomy and eventually placing the implant, okay? Now, initially, this tube is going to be as part of the virtual guide right in here. You can see how it looks like in the virtual world. And it has set dimensions. Now, they're not random. They're based on the osteotomy that you're creating. It's based on the implant that you're using. The guided software, the guided company that is making your guides has the appropriate sleeves. They're made out of usually titanium or some other type of metal, and they're being embedded into the guide. Okay. Now, it so happens that the tube is critical. And here you see one example. What if you planned an implant in position and it looks great, and this is exactly where you want it, in between the teeth, in the right restorative position away from the buccal plate, but in order to place it in this position, because one of the teeth is malpositioned, your tube engages the tooth structure or the root. So the software is going to give you a warning and tell you, hey, doc, meaning in computer language, telling you, it doesn't work. You submit your plan to a company, call you or email you and say, you know what, it doesn't work. You got to change the implant position. Okay, and there are some solutions for that. Okay, so first of all, just to know the important points, critical points, to fit in between the teeth. Okay, it needs to have some space. It cannot touch teeth. It cannot touch another tube if you're placing implants that are side by side, and it cannot touch bone, because if it is within the bone, the guide will not see it, or cannot touch tissue if you're doing a flapless procedure. And it needs to be retentive, meaning there needs to be enough plastic around it so you can basically have the tube in there so it doesn't fall off. Okay, so there's some critical points in here. Now, there are some solutions. If the restorative space is relatively narrow, then the tube can be designed in a way, and some software allow you to do it, Blue Sky Bio being one of them. And also the software by Sirona is a great software. Psycat. Psycat is great, and that allows you to place your tube above you, which creates another problem. The other problem is, if you see it in a second, actually in the case, occlusion, you need to use extra long, not putting your there's only spin up. Okay, so just be aware and don't get disappointed. Perfect implant, and you wanted to schedule the surgeons. Doc, we need to change something. It's not going to work out. Your tube, I wanted to bring it to your attention. Can guides be inaccurate from time to time need to abandon the implant placement? Yes, absolutely. I've had cases where I needed to abandon the implant placement. I abandoned because if I miss you with a plan, okay, I'm going to continue with a bad plan, if you know what I mean. So, which happened this morning. Sometimes there are certain inaccuracies that are your fault. You took the wrong impression. Good models. Sometimes moved in the CT scan. There was accuracy in the data to the surgery. This is why I encourage you, when at surgery, don't just close your eyes, drill for the implant, and place it. Make sure that you have an open mind. Okay, it is not a perfect. It's not a perfect procedure. It's pretty close. It's way more perfect. The human hand of the one of the doing it freehand guided surgery, but procedure. But it's the best we have. So yes, there are certain inaccuracies, and I'm certainly going to show you indications and problems that I had. Okay, so let's talk about this case. Let's review the case. I hope you were able to some of these videos. If you're watching this as a recording, if not, you have the opportunity to pause this video right now, pause the live training, and go back and watch the first videos. So the live training is posted in the same module. So this live training is posted as the last videos of module number 1. I recommend you watch the first videos first. Why? Because they'll give you kind of an idea, give you just the concept of looking at data sets in the digital world and getting your fingers wet and playing with the buttons and getting frustrated and making all the mistakes that I mentioned in the videos. And then watch the video now, because I'll show you how the surgery worked out. And then you can tell for yourself, was that accurate? Was it inaccurate? And that's just a better learning experience. You don't rush, okay? We have a lot of time. You can stream this video when you have the in between patients, or whenever you can. Okay, you paid for this course. I want you to benefit from it. So you have 2 videos with Blue Sky Bio, 1 video with Simplant. Okay, so let's talk a little bit about this case, which is, again, 90% of what we do is relatively simple. And let's try to learn from this case and try to apply it in our practice. Came in, not an old patient. She's been in our practice for a long time, but one day she came in and she says, you know what, lower right-hand side hurts. I have lots of pain. I can't chew. Something's wrong. Okay, first thing we do, we take a radiograph. Maybe something is going on in the furcation area, but all in all, bone looks pretty. But anytime the patient has biting, spontaneous pain after so, I can't help think about the fracture. It's just, and what's going to fracture the weakest link. Okay, but we didn't do anything. Everything looked, clinically looked fine. A couple of months later, the patient still had pain. So came in, this time I probably took a better radiograph, more orthoradial. Now you see bone loss in the furcation. Okay, bone loss. Is this a periodontal problem? Well, this patient is not a periodontal patient. What's the possible diagnosis? Dentistry is not that complex. Not that complex with these types of situations. What can it be? Yes, it can be a localized foreign body reaction, peri disease, enamel pearl, all these rare things. But the more likely explanation is this patient had either a crack or a perforation of the root canal at the time of treatment, and clinically really tells the story. There's a draining fistula right there on the buccal, but then as the fistula appeared, he said, it doesn't hurt me anymore. So can you tell me can you assure me that this tooth is cracked? Can you show me? Can you show me the crack? And I said, no, I can't show you the crack. the side effects of the crack, because once the tooth is cracked, then bacteria from the mouth travels along the crack, infects the bone. Sometimes we call it here. It looks like a crack, it sounds like a crack, it feels like a crack. It's probably a crack, but some patients want hard proof, and we can't always prove that. Okay, so now I would never make a patient feel bad, and just tell them, listen, best of my knowledge, in my experience, we've seen, I don't know, hundreds, thousands of these cases. They all ended up being cracked teeth or infected teeth, okay? And it looks exactly like that with a fistula. Sometimes it's more apical. Sometimes there's a deep pocket in there. But let's try to image again. Let's put a good aperture marker. How do you know? How do I know? I'm taking an X-ray. It leads me into probably the broken root. And the patient said, now I'm ready to extract the tooth. You showed me, suffered for some time now. You showed fistula, there's a sinus tract, pasted to the broken root. Let's pull the tooth, okay? So sometimes it takes time. Here's my advice to you from a patient management point of view. Don't be the know-all doctor. Know all, show your knowledge, you know everything, you've done so many things in your life, and you're so famous and important. That doesn't sit well with patients. All you can tell patients, in a very humble way, tell patients, you see, all this that you're presenting with are pointing to a root crack. But all the signs and symptoms show have a cracked root. And the concern is you don't have a crack, you have a persistent infection. Treat. We're losing bone at the same time. The whole bone around this tooth is melting. Besides, it's not good to have an infection in your mouth. So that many times convince the patient to move forward. But don't come from a point of view of you telling the patient, because you come up with the conclusion many times. You can recommendation. Okay, extraction of a multi-rooted tooth, reading the money tooth book. It's better to split the tooth, split it with or without the crown. Now, personally, I prefer not to go through the crown. It just takes longer. Some of those crowns are, zirconia and metal. You have to go through multiple burrs. It takes time, lots of drilling. I would use a universal forceps first, and probably over 50% of all times, maybe close to 70%, the crown will just come off. It'll come off. Now, all you need to do is split the roots. And I'm going to use a straight carbide burr, split the root split it buccolingual all the way through. Don't be shy. Split it all the way through into the furcation bone. Try to preserve the furcation. So one way is to gauge the root trunk and see how wide it is, so you don't go in and wipe out the radicular bone, and then remove each root separately. Now, pay attention to the adjacent teeth. If they are restored with crowns or porcelain veneers, porcelain restorations on laser, sometimes by placing a straight elevator, mobilizing the adjacent teeth, you can break something adjacent. Okay, just be aware of that. So here it was actually relatively simple. There was already part of the buccal plate was missing, and each root came out. This is, of course, the broken root. The mesial root was completely cracked, like we anticipated. And as we talked about before in previous videos, study the socket. Count the number of walls. We said ideally the maximum would be 10 walls. And then try to make a decision whether you want to flap or not to flap. And there's really no right or wrong here. If I feel that I cannot debride properly, the infection has been there for a long time, very tenacious periapical infection, I would reflect a flap. But what is the risk? Reflecting a flap, and I mentioned to you lessons, I forgot which one, multiple lessons. If you or a kind of a, this is where it's going to tear. Careful with your flap reflection. Just be very, very cautious. Start from the sides in, work at the fistula area or the sinus tract area because that's the weakest spot. Extend it at least one tooth on each side and very carefully until you're exposing the full defect. And you can see that the majority of the buccal plate is missing. Why? Because we waited a little bit too long. It's not cool. Too long, too much destruction. That's going to compromise your implant site. So an important, or, oh, there's no video. Now we have it. Anthony, let's see. I'm going to take a little break here. Anthony, can you tell me if you can see the video? Okay, this is actually a new case, so I don't know if you've seen it. There's no video. Can you hear me and see me? See the slide where it says important message. Wow, today we're having a lot of these. Tell me if you can see me. No video, great audio. Okay. I want you to see what I'm seeing. No. Okay, we're gonna do some testing right in here. You can hear my sound, hopefully. Let's see. But yeah. Oh, good. That means that it's being recorded. Okay, that means it's being recorded. So we're doing good here. Okay, you can see it now, Anthony. Okay, good. Check your internet connection. Sometimes it goes in and out. Perfect. But thanks for letting us know. So my important message is delay the extraction. Listen, tell your patient just the way it is. Tell your patients, listen, no pressure. You can postpone the extraction. It's not my mouth. This is your mouth. You have what we call patient autonomy. Okay, the patient is autonomous. They can decide on what they want to do, what they don't want to do. But you have to give them some fair warning. If they have a purulent infection with a sinus tract for days and weeks and months, that's the outcome. They'll have a total blowout, which is going to compromise their implant site. Why would they want that? Okay, so that's the very obvious message. Now, looking at the socket, and we talked many times about the compartment technique. If we have a missing buccal plate, we're going to complete it. And I don't remember if I used only a PRF membrane, but typically when I have a large defect, I'm going to be using a collagen membrane layered with PRF. Okay, you don't have to use PRF if you don't have it available. You don't have to use it, but I think it's an advantage if you can offer it to your patients. It's one of the things I'll work with you on in our hands-on course here in November, how to utilize PRF, how to use those membranes, how to combine them with a collagen membrane. We'll have a lot of fun with this. But you need to complete the missing buccal plate, condensed bone graft, allograft, I mentioned before, 0.25 to 1 millimeter particle size, and you can find this information in IGR. I think it was IGR number 1. One of the first trainings was on creating great implant sites. Okay, so very routine socket grafting using the compartment technique, membrane on the buccal, allograft, and a sealing. It could be a collagen plug, it could be a PRF plug. It's really up to sutures right on top. Okay, very, very simple. Now, what happens to the fistula? Okay, the fistula is there. It's going to close up. Okay, it's going to heal because the source of the infection is out. And if you look carefully at the ridge, you're going to see a collapse. Why? Because we are not able to regenerate the original buccal plate. That's the reality. That's the reality, okay? So the sooner you understand the reality and know that a big infection, when the buccal plate goes, even if you have it initially, it will resorb, not because you did something wrong, but because there's no tooth, no more stimulation from the PDL. And using the compartment technique or any type of grafting, with the exception of the socket shield, which we will get into in the next training, your buccal plate is going to shrink down. Not shrink down to a point where you can't place an implant, but you'll get some shrinkage. So there is an option to overbuild. Absolutely. You can overbuild with an allograft. You can overbuild with BIOS, expecting the shrinkage. That's a very good comment here in the chat box. But remember the saying, nature laughs last, okay? Nature laughs last, meaning if there's no tooth, it's going to shrink, even if you put BIOS. Now, every case, no, but most cases will shrink back, okay? Give it a try. I don't discourage you, especially Anthony here, who's the main participant in our training live. I don't discourage you from placing BIOS. Go for it. What you'll find out if you try to be, let's call it the hero, and overbulk and overgraft, this bone needs to be vascularized. Anthony's laughing. This bone needs to be vascularized. So it has the potential to get infected if it's not vascularized. So be very careful in regards to how bone you're sticking in there. Be reasonable, okay? By the way, we have a training is fully Australian today.
No, right?
Okay? Australian doctor from Sydney, Australian doctor from Melbourne, and Beverly Hills, or Israeli guy, you name it. Okay, so you can overbulk, but not too much, okay? So the question is now, okay, we site healed, I wait at least 2 months. When do we take a CT scan? Good question. There's really no proper guidelines or knowledge out there. When is the right time? Because every case is different. So for the very least, wait 8 weeks. Okay. Take a look at maybe some particles that are not at the coronal part of the socket. Okay, look at the interseptal bone. It's still there. It's healing nice, but you know what? I'm going to wait. He put his Australian flag. Anthony, you're a proud Australian. We're proud of you, and we love Australia. We love the down under people. I love the Australian, nicest people in the world, and good looking too. Make everybody look bad. Lots of good looking people in Australia. No offense. So the story of this socket, you see, I would give it a couple more weeks because it's not fully mineralized. Think about a socket. How does it heal? It heals from the sides in, from the bottom up, okay, from apical to coronal, from the sides inwards. So the least mineralized part of the socket is going to be where? At the top and inside, which is exactly where the implant goes in. So I give it a little bit more time. I take a PA, wait for it to heal, mineralize for a little bit, okay? Now, this patient procrastinates, doesn't want to have her teeth pulled right away. So for 3 months, I was ready to refer for a scan. She's ready for the CT scan, ready for impression. So it has to be full arch, just to make sure that you understand that. Arch impression, not just a quad. You need that to fabricate your guide. Then you take the data, submit it to the company. It can be service or send them a CD. Better to go through the cloud. It's greener, easier, less parts and pieces involved, less risk of inaccuracies, and submit models or an optical scan STL. I hope that by now you understand how the STL works. Now, you did the data, the company made the merge for you. If you use Blue Sky Bio, you do the merge yourself. Now you can study the site, you can study the anatomy. You can see that this patient has an anterior loop of the inferior alveolar nerve. Okay, so here's the IAN traveling in the jaw from a coronal position to apical position, passes the mental foramen, moves forward and loops back, and can loop back up to good 5 millimeters, around that average, but it can be more. It can be more. So if you're interested in learning about CT scans, go to Speak CT. There are a bunch of videos there, I think like 10 videos, where you can learn about the important anatomical structures. Okay, so the anterior loop of the inferior alveolar nerve, it looks kind of close, but luckily the molar implant is really far. I mean, this implant was planned as a 13-millimeter implant. Okay, so here we're looking at the buccolingual section. Just so you have an orientation, here's the cross-section of the inferior alveolar nerve. We have the very dense cortical bone of the mandible. We have the cross-section of a virtual wax-up. Okay, you learned how to do this in CGI Box, and you've seen the videos how I create a virtual wax-up. Now, if you're not comfortable doing that, that's totally cool. You don't have to. You can use a denture tooth for a single molar, not a problem. Use a denture tooth and submit the model, or create an actual wax-up. It's really up to you. For single missing teeth, between teeth, you can definitely use a virtual wax-up, and I explained this in the previous videos in this module. Okay. Now, what I want you to pay attention to in this section is the buccal plate. It's not a bad ridge. This is a 5-diameter implant, but there's a chunk missing. I don't want you to ignore it. So really, these cases are almost ideal for a contour graft. And when we get there, I'll talk a little bit about contour grafting, because obviously the socket preservation or the socket grafting procedure was not able to preserve. That's why we probably shouldn't use the term socket preservation. Okay, we minimize the resorption, we have a reasonable ridge, but we're still missing a chunk. So this is a really good indication for a contour graft with slowly resorbing. To develop a skill, as you go through modules and guided surgery, I'd like you to develop a skill that develops, after a couple of weeks, where you look at two views at the same time. So you look at the cross section and you look at the 3D view at the same time. So when you make some changes on the cross section, you'll see some clinical changes here. You'll see the trajectory of the implant is changing. You'll see the screw axis is changing. And it's like, I don't know, it's like driving a car. You don't really think about, shifting gears or, pressing on the gas, or pressing on the brake. You don't really think about that. It's more, becomes second nature. That's okay. So here's the preoperative apical kind of periapical. And when we think about mesiodistal angulation, because this is what's the ideal angulation? Look at the adjacent teeth. One tooth is well positioned. The other tooth, the second molar, has a mesial tilt. How do you decide? Who do you go by? Premolar? Do you go by the molar? Do you split the difference? Sounds kind of basic, but let me give you a guideline that works really well. And I also the guideline. Like the mesiodistal trend, I'd like it to the contact areas of the adjacent teeth. Okay, now in a scan, even in a very well merged file, you can't always tell the angle of the contact. Not perfectly, but you have an idea. You have an idea, because the contact area of a molar is pretty flat. Why is that important? If you parallel your implant with the adjacent contact areas, you'll get better contacts. Don't you want that? That's really important. Your patients, trust me, could care less about the position of the implant. They care about contacts, food impaction, good flossing, okay, very important, and cares about the embrasure space. Okay, if you malposition an implant, yes, it will integrate. Yes, it'll be restorable, but the embrasure spaces will not be ideal. Okay, so I'm talking about screw retained crown. So think about the need for a draw. Okay, draw and place a fully screw retained crown on the implant. You want this to draw and have the ideal contact areas and ideal embrasure spaces with the adjacent teeth. That's where a lot of doctors fail. They place an implant, it's in bone, it heals, they did well, but it can be better because your patients are like, oh, wow, that's great. I have a tooth, I can chew, I'm happy. 2 months later, they'll tell you, no, doc, I love the implant and I think you're great, but why do I get food? Now, implants under the normal circumstances, even under the best conditions, where the implant is, let's call it perfectly placed, they still have problems. They still have not the ideal contacts, not the ideal embrasures. Why? Because you have bone resorption and you have tissue resorption, and the whole complex is not a tooth. It's the best we have after a tooth is gone. But paralleling the mesiodistal angle to the adjacent contacts is going to be a tremendous help for you. And I'm giving you a guideline when you work working in the software. Again, look at the two views at the same time, develop the skill to change an angle of an implant in one plane, what happens in the other view. Again, this is something that will come with time, okay? Before you're completely done, just look at the trajectory, make sure that you have a screw access, and don't worry about the soft tissue architecture at the moment. This is something that you'll address during the procedure. You'll address that, okay? You need to know how to perform surgery. This is not just how to plan in the virtual world. This is only one component, okay? Now, before we move to the actual procedure, let's talk a little bit about the length of the implant. I planned for a 13 millimeter implant, which is relatively long for a molar. Why? Because I had the bone, okay? I could go with 10. 10 is reasonable. 11.5 is reasonable. 13, I felt, wow, I have so much bone. Why not take advantage? Now, the trick part here, okay, if you think about placing an implant through, what you're seeing now is a representation of the computer guide, is that all these numbers are going to start adding up. So if you have a 13 millimeter long implant, plus the tube, which is probably about 4 millimeters, plus the distance between the two, and that really varies, plus fixture mount, the fixture that delivers the, let's say, the 13 millimeter implant has also some length to it, probably 7 to 8 millimeters, and that may not be 100% accurate. Plus the handpiece size. You know what? Your patients, sometimes for lower molar location, not so much the first molar, but mostly second, there's going to be a limitation of a mouth opening. Okay, we're not treating crocodiles. They can't open that wide. Okay, so here are some solutions. Some solutions for mouth opening. Number one, you can use shorter implant. Bone for 13, go with 10. You can save 3 millimeters. You can pre-assemble the guide and the keys in there. You can just pre-assemble. You can even put the drill into the key, into the guide outside the mouth and assemble everything in the mouth. That's one way to do it. You can start with short drills and slowly get what we did this morning. Short drills and get longer and longer and longer. And sometimes it's not possible. Sometimes you have to just abandon the guided option. It doesn't mean you don't do the planning. You can drill guided and you have to place the implant freehand. Okay? I don't want you to feel bad. Sometimes you run into these situations, and that's just the limitations of treatment. Okay? Limitations of treatment. So here's some solutions. Okay, so here's the digital representation of the guide. Let me show you how this case turned out. Looking at the side, we saw the collapse of the buccal plate. Not bad, but it is collapsed. So the last thing we want to do is do a flapless procedure, because we can take advantage of all this good tissue and displace it to the buccal. So the flap design that I would choose is a full thickness flap, making the crestal incision more to the lingual. You see, things don't have to be complex. This is very, very simple to do. Technically, it's very simple. All you need to do is an intracircular incision on the molar or the adjacent teeth, and maybe put your guide in, see where the trajectory is or where the entry point is, and make a straight incision to the crest between the line angles, and then connect everything and reflect the full thickness. Okay, that's relatively simple to do. If you want to complicate things and add a soft tissue graft and do other things, that's okay too. I'm not saying you can't do grafting here, but if you can utilize the tissue on top of the ridge in your advantage, in the patient's advantage, and get some good attaching keratinous tissue in front of the, to the buckle of the healing abutment, it's free and it's simple to do. So remember, simplify, simplify, simplify. That's really the key to success. Don't overcomplicate things, okay? Now, if you now made a mistake and you made your crestal incision too much to the lingual, you made it here, you made a mistake, okay? So it's not the end of the world. But once the implant is placed, you'll have exposed bone. So you may need to, if you made this mistake, which happened to me, you may need to place the implant, place a cover screw, bury it, and uncover it properly, because you don't want to have exposed bone, okay? By the way, it's great to have me in the room. Usually I'm by myself, okay? To drill the osteotomy through the guide, remember, I'm taking radiographs during, even if I'm doing it guidedly, I'm taking at least 2 or 3 x-rays before I place the implant. Why? I'd like to make sure that I plan properly. Now, what's happening with this x-ray? Am I misplacing it? Is that a misplaced implant? Okay, well, the angle, if you look at it, may not look ideal. At the different angle x-ray, okay, looks pretty good. So my message here is, don't just look at an x-ray. You know what, I don't like the angle, let me change it, because the x-ray may be wrong, because the second molar is significantly mesially drifted. Okay, now you may say, hey, Ziv, you probably should have done some molar uprighting. And that's an option. But in the real world, reality says, the patients, like, give me a tooth. Give me a tooth. I'm not going to go through ortho now and upright the molar for 3 months and pay a couple more $1,000 so I can have a molar that is 12 millimeters and not 10 millimeters. Okay, so we have to be realistic. That's not to say that uprighting is wrong or uprighting should not be done. I do upright teeth, meaning I don't do them myself. I work with an orthodontist, but not for every case. Okay, we have to be reasonable. Okay, so the message here, don't treat the x-ray, treat the patient. Treat the patient, okay? And make sure that you take enough x-rays and diagnostic x-rays that show you angle. So here's at the completion of the osteotomy. Very good bone that healed, and actually a cortical plate that is a little bit collapsed. That's a great indication for a contour graft. So it's ideal. Now, I'll be honest, I don't graft in this case. I don't remember. I think I did. And that's what it looks like when I sutured. But if I didn't, then I should have. And the way I would have done that, if I didn't, is place the implant, slowly resorbing bone graft material like bios and a membrane. And I've showed this in so many different videos. And it's really here as the flap adapts around the healing abutment. Okay, so I hope you're seeing that the plan that I created in Simplant and Blue Sky Bio is now becoming reality. And for your first cases of CGI, you're going to be in like a seventh heaven. You'll be amazed by the accuracy and precision. This is a simple case, and by the beautiful distribution of space around the implant, by the ease of placement, by the better restorative outcome. Why? Because you placed an implant after careful planning, careful analysis, and the implant is placed in a very precise and accurate way. Okay, now maybe I should have placed it a little bit more to the mesial. Okay, but I paralleled it to the adjacent contact areas. But I just wanted to show you that the actual execution of the plan is extremely, extremely accurate. So the conclusions and the kind of the lessons learned from this module are that we should ideally parallel to the adjacent contact areas to create better embrasure spaces, better contact areas, that we need enough vertical space and mouth opening. It's hard for me to give you the exact calculation and give you, if the patient opens 40 millimeters, it's enough. Well, you have to test it. You'll have to, during your implant consultation, get a handpiece without making it work. Just put it in the patient's mouth to see if they can open wide enough. And sometimes unfortunately, will not be able to do guided surgery for a lower second molar. But to be honest, it's very uncommon, okay? So vertical space is important. And looking at x-rays during, and in case you misplaced or misplanned, it'll be good for you to reorient yourself, okay? So I hope you found this lesson helpful and practical and valuable, and how we use guided surgery, starting in the virtual world and planning it and turning it into in CGI Box training, CGI Box Live. We are moving to the aesthetic zone, and I'm going to show you the replacement of an upper central incisor. I'm going to show you the socket shielding and how we use it and how we, what are the benefits, and show you some of the results. And it'll be awesome. So if you want to gain the maximum from CGI Box training, and again, this is a type of training that was not available or is not available anywhere else. And there are other guided courses, but there's really no take-home course anywhere you're at in the world. Use the CD, use the software, follow the lessons. You can really learn how to do this and how to perform guided surgery in your practice, okay? So my advice to you, if you want to take your skills to the next level, go through at least the videos, okay? No pressure, because that's why I created this type of streaming course. Anytime you have time, anytime you have a spare moment, watch the videos, but you will not get the results by osmosis, by having the DVDs or CDs on your desk. I know they're kind of cool. They're kind of cool design, with the, I don't know, they're mystical, kind of the mysterious. But you need to actually go through this to get the results. Now, here's the good news. If you go through them, you're more than a few steps forward and closer to performing CGI in your practice. So I hope to see you in CGI module number 2. That's going to come next, and I'm going to send an announcement for that. Now, Anthony is asking, do you still make a guide even if you think you won't do guided surgery? No, I don't do that. I don't want to waste, a couple $100. But my intention is to do every case guided, and I do every case guided. If for whatever reason it so happens that my out or patient could not open enough, then I have to unfortunately differently. But yeah, I always fabricate a guide. I'd like to say the majority of all cases, over 95%, is used in good use. So the lesson learned from guided surgery really is okay. So thank you so much for watching this video. Thank you so much, Andy, for attending this live here next to me, to my left. And leave some comments and questions below. You can perform surgery at a high level. I don't want you to belittle what you know already. You know a lot. You just need to put it to the use. You need to tweak your knowledge. You need to tweak your experience. You need to get in there, get those surgeries going, get those surgeries booked. Don't be hooked on perfectionism. Perfectionism is very important, but you'll never get there. I'm not there, okay? Our procedures can be excellent. There's always better. We always constantly improve, and we need to build on our confidence. We need to have patience until we develop our skills, okay? So until the next video. I look forward to seeing you in all the other CGI Box Live. And we have Andy here wants to say final words. Andy, microphone is yours. Don't worry about it.
Thanks, Ziv. It was a fantastic live seminar for me. And my name is Dr. Andy Kumar. I practice in Sydney downtown. And I'm very happy to say that it's a full testament to you, Ziv. And guys, you have joined one of the wonderful courses. I also joined it recently when it's been launched a month ago. And whatever Ziv has mentioned in his videos or the seminars is absolutely, the information is 100% correct. He is teaching what he preaches. He is doing the stuff which he talks about. And I've seen it live. And this information is 100% correct. He's very practical oriented, which means day-to-day common scenarios which we see in our life. Nothing academics, fully practical, and it's for, I think, guys like me who have more time, who spend more time in the practice rather than going through the books and doing the assignments and things like that. So it's 100% practical course, and I think even that gives me much more time to think. Like, I need to go back to the videos and see the videos more repetitively so that we can gain more and more knowledge. I think, Ziv, for your videos, I cannot say I've seen this video once. I should see each and every video maybe 10 times,
absolutely.
Right? So that's so good. Guys, it's late evening now here, and it's 6:30. So it's really nice to see Ziv in his practice. Talks different things, practical things, fully clear, 100% clear, and it's all practical. He's totally 100% honest person, and he's lovely and charming.
Here is lying. That's the only part that was inaccurate.
No, I wouldn't say that.
No, listen, guys. Most of you will listen to this as a recording. I do my best to teach, to practice what I preach.
Yeah.
To teach the things that I do in real life. And Andy was here this morning. He saw how many x-rays we took. He saw a case where I misplanned the case and how we made some adjustments. So real life stuff. And the idea is for dentists not to just kind of follow the Facebook and follow famous speakers all over the world and seeing glory cases and everything is so complex. You know, we have to get down and dirty and treat our patients and our practices with the common cases. So what I showed you in this training was a simple case. This was not a difficult case, but you see, we talked about it for an hour and a half.
Yeah.
An hour and a half on a simple case, and because I focused on some important nuances that not everybody is aware of. So Andy, thank you so much for the feedback.
So like even for the x-ray you showed, right? So if you take one x-ray, you can go wrong if it's not a guided surgery. You can actually change the angulation by looking at just one x-ray and change the angulation, right?
Exactly. So Andy's referring to the x-ray that I showed you. It was if it was free-handed and the x-ray was wrong, we changed based on that. Basically, we're treating the x-ray.
We're treating
to treat the patient. Okay. Andy, thanks so much for your feedback, guys. Leave comments, questions below, and I'll see you live training. You'll get an email from me. Take care.